We are presenting the case of a 29 years old man with a complex congenital heart disease who underwent a previous Fontan palliation. The heart was dissected free from many dense adhesions. The aorta was then isolated and an umbilical tape was passed around. As you can appreciate, the aorta is on the left, and in the middle you can see the pulmonary artery. In this case, we decided to establish a cardiopulmonary bypass with an arterial line into the aorta and the venous line into the innominate vein. Here we are positioning a vent into the pulmonary artery, and then we position a cannula into the innominate vein. A clamp was positioned on the SVC, and then a clamp was positioned on the aorta. The aorta was transected, the pulmonary artery was transected as well, and the heart was excised. The SVC was disconnected from the pulmonary artery, and the pulmonary artery was reconstructed using the heterologous pericardium. The connection between the conduit and the pulmonary artery was closed with the heterologous pericardium, as well as the connection between the SVC and the pulmonary artery. Since the bifurcation was on the right side compared to the aorta, it was closed with the heterologous pericardium, and later we will open the left pulmonary artery to relocate the main pulmonary artery from the donor. An adequate left atrial cuff was created, and the sutures were positioned in order to move the left atrial cuff towards the right side of the chest. And left atrial vent was positioned through the right superior pulmonary vein. Once the donor heart is available, the left atrial cuff is anastomosed in the usual fashion. Then is the turn of the IVC, which is anastomosed in the usual fashion. The patch that was positioned on the pulmonary artery is open to relocate the donor pulmonary artery that obviously is on the left side compared to the aorta. The aorta is then anastomosed a root vent is positioned into the donor aorta for the airing, and finally the superior vena cava is reconnected to the right atrium with the interposition of a reinforced Gore-Tex conduit. After careful de-airing, the clamp is removed and the heart is back on sinus rhythm. As per our protocol, the chest is left electively open in order to have an easy access to the heart and a more stable hemodynamic during the orthotopic liver transplant. The skin is closed with the interposition of an S-mark membrane. Thank you for staying with us.